Good afternoon, everyone. In this session, we will take anatomy, starting with synovial joints, shoulder and hip joint. They are example of ball and socket joint, where one bone forms the socket and another forms the ball. So this is an example of ball and socket joint, and it permits movement in many planes, so multi-axial movements. Then another type of joint is a hinge joint, and the classical example is elbow joint. And here the movement, it occurs only in one plane, just like a hinge of a door. The movement occurs only in one plane, so there is only flexion or extension. Then third, superior and inferior radio-ulnar joint. Now these are examples of pivot joint. Another example of pivot joint is C1, C2 vertebra, which is atlanto-axial joint. Clear? So this is atlanto-axial joint. So here one bone forms the axis and another bone rotates around that. So this is pivot joint, right? So superior inferior radio-ulnar joint and atlanto-axial joint. Now please note that there is one middle radio-ulnar joint, which is actually interosseous membrane, right? So this is not a true joint, it is actually syndesmosis. Clear? So this is syndesmosis. So this is interosseous membrane, and this is actually syndesmosis. Okay. Clear? So just superior and inferior. Make sure that you don't mix up with the word middle. Middle is not a synovial joint. Clear? So this is, middle is actually syndesmosis. Then especially related to the base of the thumb, that is first carpometacarpal. This is an example of saddle joint. So this is the first metacarpal, right? And it articulates with the trapezium. So this is an example of saddle joint. So these are some important synovial joints from exam point of view. Then moving forward to cartilaginous joints, there are two types, primary and secondary. Now the important example of primary is the joint between epiphysis and diaphysis, and this you can remember as growth plate, right? So this is primary cartilaginous, also known as synchondrosis. The secondary cartilaginous is also known as symphysis, and again you need to remember the word symphysis in examples. So one is pubis symphysis, another is symphysis menti. Clear? So you can remember with the word symphysis. Now one of the property of these secondary cartilaginous joints is that they are in the midline of the body, right? So like if you remember symphysis pubis, it is in the midline. Clear? So they are in the midline. Then moving forward to fibrous joint, there are few examples. Like one is tooth in socket, and this is actually known as gomphosis. Similarly, the skull component bones, they are held by sutures, and syndesmosis we have already discussed. It is between two adjoining bones like tibia and fibula, and another we have already discussed, radius ulna. So these are examples of fibrous joints. Then moving forward to epiphysis, head of femur is under continuous pressure of body weight, so it is known as pressure epiphysis. And one more thing you can say, that these are articular. Articular means they participate in joint formation. Some other type of epiphysis, they give attachment to muscles like tubercle of humerus, mastoid process, and also trochanters. Right? So they give attachment to muscle which exerts a traction. So these are known as traction epiphysis. So muscle attachment. Now these are not articular. Clear? And then third type of epiphysis is atavistic epiphysis, where the bone, the epiphysis actually originally it's independent, but later on it fuses with some nearby bone. So later on fuses to some nearby bone. So this is like classically this is coracoid process. It becomes a part of scapula later on. So these are different type of epiphysis. Then sesamoid bones, they develop in muscle tendons, and the classical example is patella, which develops in the tendon of quadriceps femoris muscle. Right? So these lacks periosteum. Then some clinical condition which presents as bleeding. So what is the source of bleeding in those clinical conditions? One is, of course, you must have read that a duodenal ulcer might bleed, and the source is gastroduodenal artery. Extradural hemorrhage outside the dura mater, and this is arterial, middle meningeal artery. Then subdural, underneath dura, between dura mater and arachnoid, this is venous, so emissary veins. And after tonsillectomy, that is surgical removal of tonsil, bleeding can occur from paratonsillar vein. Then there are certain triangles in the body. One is triangle of auscultation. Many times you must have observed that a physician always put the stethoscope on the back of chest. So actually he is putting the stethoscope at an area where the respiratory sounds can be heard better, as there is no muscle covering. So that triangular area is the triangle of auscultation. Now it is bounded medially by the trapezius. So the medial border of the trapezius forms the lateral border of the triangle. Then laterally, the medial border of the scapula forms the lateral border of the triangle, and inferiorly there is latissimus dorsi. Clear? So this triangular area is known as triangle of auscultation, and here the respiratory sounds are heard better. Clear? Then another triangle which is very important in surgery is the Hasselbalch's triangle. Now this Hasselbalch's triangle is the site of direct inguinal hernia. Clear? And the boundaries are like this. The medial boundary is formed by the rectus abdominis muscle. The lateral boundary is formed by the inferior epigastric vessels, and the inferior boundary is formed by the inguinal ligament. So this is the triangle here, and this triangle is known as the Hasselbalch's triangle. Clear? And this is the site of direct inguinal hernia. Clear? Now one more triangle, and that is important in ENT, and this is McEwen's triangle. Here on the upper side there is supramastoid crest. Okay, so this is the supramastoid crest. This part is the postero-superior margin of the external acoustic meatus, and thirdly we have to draw a tangent, right? So a tangent has to be drawn, and this converts this all area into a triangular area, and this triangle is known as McEwen's triangle. Now this triangle is important for reaching up to mastoid antrum. Clear? So these are few important triangles in human body. Then some lymph nodes and the areas they drain. One is Cloquet or Rosenmuller lymph node, which drains the clitoris and the glans penis. Then pre-aortic and para-aortic, they drains the testes. Then submental, it drains the tip of tongue. And then spongiform urethra, it goes into deep inguinal nodes. Then some important veins in the body. Left gonadal vein, it drains into left renal vein. Clear? Whereas the right gonadal vein, it drains into inferior vena cava. Clear? So you can see the difference. On left side it is going into left renal vein, and on the right side it is going directly into the inferior vena cava. There is one great cerebral vein, it drains into straight sinus. Portal vein, it is formed by the union of two veins. So one of the vein is splenic vein, another vein is superior mesenteric vein, and it finally forms the portal vein. Clear? So this is portal vein, this is splenic vein, and this is superior mesenteric vein. Clear? So this is how they join to form the portal vein, and this all happens behind the neck of pancreas. Clear? So this union occurs behind the neck of pancreas, and normally the pressure in the portal venous system is 5 to 10 millimeter of mercury, and if it goes beyond 12 millimeter of mercury, you will call it portal hypertension. Clear? Then fetal physiology is quite different from adult physiology, and there are certain structures which hold importance during fetal life, but they are replaced by some fibrous tissues in adult life. So one structure is ductus venosus, which is a fetal structure, and in adult it persists as ligamentum venosum. Another important structure in fetal life is ductus arteriosus, which persists as ligamentum arteriosum, and one structure is left umbilical vein, which persists as ligamentum teres. So this is actually left umbilical vein because the right one disappears. So this is ligamentum teres. So these are three important structures which are very important in fetal physiology, but are replaced by some fibrous structures. Then derivatives of neural crest. It gives rise to neurons, it gives rise to Schwann cells, melanocytes, and many more structures. So neural crest is very important. And then only one structure in the body has representation of all the three germ layers, that is ectoderm, mesoderm, and endoderm. Clear? So this is tympanic membrane, which has representation of all the three germs layer. Then there is one important duct, that is Mullerian duct, which is also known as paramesonephric duct. Now this is very important in females, and it forms uterus, cervix, fallopian tubes, and upper 2/3 of vagina. Clear? Remember, lower 1/3 of vagina, it comes from urogenital sinus and not Mullerian duct. Clear? So many times this is a question which is usually framed. Now here you can see one thing. There is no mention of ovary here, because ovary is again not a derivative of Mullerian duct. It is a derivative of genital ridge. Right? So these 2 points should be remembered nicely for Mullerian duct, which is predominantly in females. In males, it gives rise to appendix testis. Then ovary, genital ridge, clitoris, genital tubercle, and scrotum, genital swelling. So just remember this much. Then coming to pharyngeal arches. From first pharyngeal arch, there is Meckel's cartilage, sphenomandibular ligament, then middle ear ossicles like malleus and incus. The muscular component are all the muscles of mastication, and the nerve supply of the derivatives is through cranial nerve 5, that is trigeminal. So this is the mandibular arch or arch number 1. So we can see Meckel's cartilage coming from first pharyngeal arch, sphenomandibular ligament coming from first pharyngeal arch, muscles of mastication like temporalis, pterygoids, all coming from first pharyngeal arch. Then also anterior belly of digastric. Then moving forward to second pharyngeal arch, we can see there is derivative. The derivatives includes stapes, styloid process, stylohyoid ligament, and then some part of hyoid bone. Now if you look properly, many structures are starting with the alphabet S. So stapes, stylohyoid ligament, then smaller or what we call lesser cornua of hyoid. Clear? So again the word S is here, smaller or lesser cornua of hyoid. Apart from this, posterior belly of digastric, platysma, and all the muscles of facial expression, these are derivative of second pharyngeal arch, and the nerve supplied to the derivatives is facial nerve. So this is hyoid arch. So you can see the structures here, and majority of the structures starts with S. Clear? Majority. Then third give rise to greater cornua of hyoid. We already discussed that lesser or smaller cornua is from second pharyngeal arch. So lesser is from third pharyngeal arch, and from third pharyngeal arch there is only one muscle, that is stylopharyngeus. The nerve supply of stylopharyngeus is glossopharyngeal nerve, right? So this is the third pharyngeal arch. Now pharyngeal pouch. Don't confuse pharyngeal arch with pharyngeal pouch. Pharyngeal pouch are different. So you can see middle ear, auditory tube by first pharyngeal pouch, supratonsillar fossa and tonsil by second pharyngeal pouch, then thymus and some part of parathyroid from third pharyngeal pouch, again some part of parathyroid and ultimobranchial body from fourth pharyngeal pouch. So if someone asks you palatine tonsil, The answer has to be second pharyngeal pouch. Now we can see here parathyroid, parathyroid. Parathyroid has, in parathyroid gland we have two parts, superior and inferior. Now the development of these is different. The superior develops from fourth pharyngeal pouch and the inferior develops from the third pharyngeal pouch. Clear? So just note it down: superior fourth, inferior third. Right? So this is very important. So inferior from third, superior from fourth. Thymus is coming from third. And the parafollicular cells of thyroid, they develop from ultimobranchial body. So this is in short about pharyngeal pouches. Then moving forward to epithelium. Now this is a simple epithelium. Simple epithelium means there is a basement membrane. Clear? So there is a basement membrane on which a single layer of cells is placed. Okay, so there is a single layer of cell. So this is known as simple epithelium, and they all have nucleus. Clear? This is simple epithelium. Now if there are multiple layers like this, if there are multiple layers, it becomes stratified. Clear? So if there are multiple layers, you will call it stratified. Right? So simple, one layer, and stratified, multiple layers. So I think you must have heard of this term many times. So this is multiple layers. Now there is one term, pseudo-stratified. It means the layer is one but looks like multiple. Clear? So this is pseudo-stratified, and usually the cells are like this, and as a result of this the nucleus are at different levels. So this gives a false impression as if there are multiple layers, but there is only a single layer. It just, the cells are creating a false impression. So this is pseudo-stratified, right? So simple stratified, simple epithelium, stratified epithelium, and pseudo-stratified epithelium. So the mesothelium of pleura, peritoneum, pericardium, all are simple squamous. The shape of cell is squamous. Then true vocal cords, cornea, tonsil, vagina, as esophagus, these all areas are lined by non-keratinized stratified squamous. I think now you must be knowing the meaning of word stratified. Now non-keratinized means there is no keratin. There is only one place where we find keratinized epithelium, and that is skin. Clear? Other places non-keratinized. Then respiratory passage is all having pseudo-stratified ciliated columnar. Clear? Ciliated means there will be presence of cilia, so it becomes ciliated. So this is cilia, so ciliated. So the exception is true vocal cord, because true vocal cord is lined by non-keratinized stratified squamous. Now, in urinary pathway, there is transitional epithelium and it has a capacity to stretch. So, extra reserve. So, this is transitional epithelium, which is also known as urothelium, and the urinary tract like renal calyces, ureter, uretrovesical junction, urinary bladder, all are lined by urothelium. Then some important histological fractures like intrinsic factor of Castle, it is secreted by parietal or oxyntic cells in the stomach. Then there are chief cells which are also known as peptic or zymogen cells. They secretes pepsinogen and they line the body of the gland. Brunner's gland are present in duodenum, which are highly rich in alkaline mucus. Then reticuloendothelial cells of liver are known as Kupffer cells. So these are actually phagocytic cells of liver. Then space of Dissay and Moll in present in liver. Also Ito cells are present here, which stores vitamin A. Intercalated disc is a feature of cardiac muscle, and the nuclei in the cardiac muscle is single and central as compared to skeletal muscles where the nuclei is multiple and peripheral. Clear? So this is one way of differentiating. So single and central in skeletal muscles, the nuclei is multiple, peripheral nuclei. Clear? Then elastic cartilage. The examples includes epiglottis, pinna, external auditory canal. Clear? So this is elastic cartilage. Then moving to upper limb, brachial plexus is very important, derived from C5, C6, C7, C8, T1. Now C5 and C6 joins to form the upper trunk, C8, T1 joins to form the lower trunk, and C1 continue as the middle trunk. Then there are divisions and finally cords. From the upper trunk, now this is the upper trunk here, and from upper trunk there are two nerves. One nerve is this, another nerve is this. So one nerve is the suprascapular nerve and another nerve is the nerve to subclavius. So two nerves coming from the upper trunk. So nerve to subclavius, as the name suggests, it will supply subclavius muscle, and suprascapular nerve, it supplies two muscles, namely supraspinatus and infraspinatus. Then musculocutaneous nerve, it is arising from the lateral cord. Then from the posterior cord, there is one upper subscapular nerve and one lower subscapular nerve. So upper subscapular and lower subscapular are originating from the posterior cord. And this lower subscapular nerve supplies teres major. Then junction of C5 and C6 is known as Erb's point. So this is Erb's point, right? And if there is paralysis of upper trunk, the condition is known as Erb's palsy, and you will see a classical Porter's tip hand or policeman tip hand, right? So the upper limb is adducted, interrotated, and the hand is pronated. So that is the typical attitude. Klumpke's palsy, it involves the lower trunk of brachial plexus, especially involving the C8 and T1, and we can see clawing here. Clear? So this is in short about brachial plexus. Moving forward to shoulder joint, it is weaker inferiorly because if suppose this is the shoulder joint, anteriorly, superiorly and posteriorly there is rotator cuff. So rotator cuff strengthens it. Now flexion at shoulder joint is carried by clavicular head of pectoralis major and anterior fibers of deltoid. Abduction is very important because different degrees, different muscles come into play. Supraspinatus brings about 0 to 15 degree of abduction. Then furthermore, 15 to 90 degree is carried out by deltoid, and beyond 90 degree till 120 degree, this is carried by serratus anterior and trapezius. Even beyond 120 degree abduction is possible, but that is because of the scapular rotation. Clear? So one should be very well versed with the abduction at shoulder joint. This is a very unique movement in which different muscles participate in bringing out different range of movements. Axillary nerve supplies two muscles, deltoid and teres minor, and the muscles in the rotator cuff can be remembered by the mnemonic SITS: supraspinatus, infraspinatus, teres minor and subscapularis. Please note that this is teres minor. Do not mix it with teres major. Muscles which are attached to the greater tubercle of humerus include supraspinatus, infraspinatus and teres minor, and you can remember these are the top three muscles of rotator cuff which provides strength to the shoulder joint. Posterior part of shaft, there is a spiral groove. It looks like S, so therefore it is known as spiral. Since it is occupied by radial nerve, so it is also known as radial groove. In the arm, there are two compartments. Like if we take the transverse section, suppose this is the arm, right? This is humerus. Then there are two compartments, anterior and posterior. In anterior compartment, there are three muscles, and these are B, B, C. Clear? So these three muscles are brachialis, biceps brachii and coracobrachialis, and all these three muscles are supplied by musculocutaneous nerve. Clear? So what I mean to say, for anterior compartment of arm, the nerve supply is provided by musculocutaneous nerve. In posterior compartment, there is only one muscle, that is known as triceps. Clear? So musculocutaneous nerve is the main nerve supply of anterior compartment of arm. Moving forward to elbow, there are three muscles which bring about flexion at elbow, and the mnemonic is triple B. So biceps brachii, brachialis, these are both from the arm, and brachioradialis, this flexes elbow in mid-prone position. And this muscle can be easily identified in the body because it forms the lateral prominence of forearm. So it's easy to identify, right? So these are the three muscles which brings about flexion of elbow. Now these two are supplied by musculocutaneous nerve and brachioradialis is supplied by radial nerve. Fine. Now these are some important muscles which one should know. And apart from flexion at elbow, biceps brings about supination also. So it helps in supination. Moving forward to hand, now this is very important. Always and always we have a question from this segment. There are two eminences in the hand. One is thenar eminence, which is supplied by median nerve, and this is below thumb. There is another eminence which is below little finger. You can check in your hand. This is hypothenar eminence, and this is supplied by ulnar nerve. Clear? Then there are two group of interossei muscles, palmar and dorsal, and all are supplied by ulnar nerve. Adductor pollicis muscle, which brings the thumb closer to the index finger, is supplied by ulnar nerve, and this muscle is checked in Froment sign or book test. So Froment sign or book test, we check ulnar nerve injury, and actually we are checking whether the adductor pollicis is working or not. If there is dislocation of lunate bone, it can injure median nerve, and in median nerve injury we can see ape thumb, deformity, pointing index, which are the important signs. Then moving forward to inguinal canal. If you see, this is the inguinal canal, and inguinal canal has two openings. One is deeper and one is superficial. So this is deep inguinal ring and this is the superficial inguinal ring. Now these rings are actually defects. So deep inguinal ring is a defect in fascia transversalis, and superficial inguinal ring is a defect in external oblique aponeurosis. Clear? Now why we discuss this entity so much? Because at times there is hernia, like the bowel may enter through the deep inguinal ring and it may come out through the superficial inguinal ring. So this is the indirect variety. Clear? This is indirect variety, indirect inguinal hernia. Sometimes the bowel may enter through the Hasselbeck triangle, enters the inguinal canal and come out through the superficial inguinal ring. So this is the direct variety. Clear? So direct and indirect. Clear? So for direct we have already discussed Hasselbeck's triangle. Fine. So this is importance of inguinal canal. It can lead to herniation of intestines or bowel. Then moving forward to lower limb, nerve supply of medial or adductor compartment of thigh is obturator nerve. Okay, so adductor or medial compartment is obturator nerve. Then gluteus maximus is supplied by inferior gluteal nerve, whereas gluteus minimus, medius and tensor fascia lata, these are all supplied by superior gluteal nerve. Now this is the nerve which we check in Trendelenburg test, where we check the levels of anterior superior iliac spine. So this is the basis of Trendelenburg test, especially if we are checking gluteus medius and gluteus minimus muscle. Then actions of different muscles like piriformis and gemelli, these are short external rotators and also quadratus femoris. So short external rotators. Okay, so external is lateral only. And then sartorius is a very long muscle which acts at both hip and knee joint, and it brings about, if you want to sit in cross leg position. Clear? Abductors are gluteus medius and minimus, which we check in Trendelenburg test. Extensor of knee joint is quadriceps femoris muscle, which is the main muscle in the anterior compartment of thigh. And the term is quadriceps. Now, what are the four components in quadriceps? Here, this short external is quadratus femoris. Clear? And this muscle is quadriceps femoris. So make sure you don't mix up quadratus, quadriceps. In quadriceps, there are four muscles, out of which there are three: vastus, lateralis, medialis, and intermedius. Clear? And the fourth one is rectus femoris. So these are the four muscles which are included in quadriceps. Clear? Like biceps, triceps. So similarly quadriceps. Now there are certain important ligaments in the body, and one is the iliofemoral ligament, which is also known as the ligament of Bigelow, and this is the strongest ligament in the body, and the function is to prevent hyperextension of the hip. Now hyperextension of the hip, it makes sure that the body does not fall backward, so prevents backward falling of body, as if you are standing from a sitting position, so it makes sure that the trunk doesn't go backward. Then there are two cruciate ligaments in the knee joint. So suppose if this is the femur, this is the tibia, then one of the ligament is the anterior cruciate. Clear? So this is the anterior cruciate ligament. Now it will prevent anterior movement of tibia, and it will prevent backward movement of femur. Clear? So this is femur, this is tibia. So it will prevent anterior movement of tibia and backward movement of femur. Similarly, the other ligament here is the posterior cruciate. So this one is the posterior cruciate, and cruciate because they forms X like impression. So this is posterior cruciate. Now posterior cruciate will prevent backward movement of tibia and anterior movement of femur. So this is all PCL, and this one is the function of ACL. Clear? So in other terms, these two cruciate ligaments make sure that there is no movement of femur and tibia in AP direction with respect to each other. So posterior dislocation, dislocation is better you write translation, right? So translation is prevented by ACL, and similarly posterior translation of the tibia is prevented by, so posterior translation of tibia, now this is the posterior translation of tibia, it is prevented by PCL. Then posterior translation of femur, now this is the posterior translation of femur, this is prevented by ACL. Clear? So this is how you can remember, it's not that difficult. Then diaphragmatic openings. Now diaphragm is a structure which is placed between thorax and abdomen, so certainly some structures has to come down from thorax to abdomen, like aorta, some structures has to ascend up from diaphragm, abdomen to thorax, like inferior vena cava. So they need some openings from where they can pass. So for that there are three openings: vena cava, esophageal, and aortic. Now one important question which is usually asked is about the vertebral levels. Many times we have seen question on vertebral levels. There are three important vertebral levels corresponding to the three openings of the diaphragm. Like you can remember, I ate 10 eggs at 12. So I is actually inferior vena cava. Clear? So I ate 10 eggs. Now 10 is for esophagus at 12. So 12 A for aortic. Clear? So you can remember like that. I ate 10 eggs at 12. So these are the different vertebral levels. Now in diaphragm, because diaphragm is a muscle, so if we draw diaphragm is a muscle, and there is central tendon. So this is the central tendon, and this all is the muscular part, because we know that diaphragm is the main inspiratory muscle. So this is muscular part. Now the vena caval opening is through the central part, right? So vena caval opening is somewhere here. So this is the vena caval opening. The aortic, we'll take esophageal first. So the esophageal opening is through the muscular part. So esophageal opening is in the muscular part. Now the aortic opening is a defect actually. So it is not a true opening, means it is not through the esophagus, it's not through the diaphragm as such, it is behind the attachments of diaphragm. So it is actually a type of defect. So it is a osteoaponeurotic defect. So it is not through the substance of diaphragm. Clear? So these are the locations of openings: caval, aortic, esophageal. So this is esophageal, this is aortic, then this one is esophageal, okay, this one is esophageal, and this one is caval, right? So these are the locations of different openings. Now the third thing which is usually asked is the structures which are moving in or out through these openings. Right phrenic nerve passes through vena caval opening. Vagus nerve and esophageal branch of left gastric artery passes through esophageal opening, and azygous vein passes through aortic opening. Apart from azygous vein, there are two more structures which are passing through aortic opening. One is of course the name, aorta, and second is thoracic duct. Clear? So these are the structures which are passing through these. Apart from right phrenic, of course inferior vena cava will go. From esophageal, of course esophagus will also go down. So these are the different structures which are crossing through the diaphragm. Then coming to esophagus, the length of esophagus is 25 centimeter and the lining is stratified squamous, non-keratinized. Esophagus starts at the lower border of the cricoid cartilage. Clear? So the lower border of cricoid cartilage, and this happens to be the common site for esophageal obstruction or foreign body impaction, because that is the narrowest site. So cricoesophageal junction is the narrowest site or narrowest place in aorta, in esophagus. And then related to aorta and esophagus, many times we have question here. So this bronchoaortic constriction is usually around 27.5 centimeter. So this is asked many number of times, that at what length the aorta crosses the esophagus, or in fact it causes it creates a constriction in the esophagus. So that is around 27 centimeter. So please remember that. And at around 40 centimeters, the this is diaphragm. So the esophagus pierces the diaphragm. Clear? Then moving forward to thoracic duct, which is also known as Pacquiao duct, and it starts from cisterna chyli in the abdomen. So it's an elongated lymph sac of cisterna chyli. Now it goes from abdomen to thorax through aortic opening, and in the thorax it changes its direction from right to left, and the vertebral level for that change in direction is T4. So T4 is an important vertebral level in body. One is, of course, the thoracic duct is changing its direction from right to left. Another is carina of trachea. Now carina is the point where the trachea divides into right and left main bronchus. Then it is the point of angle of Lewis. Angle of Lewis is manubriosternal junction. So T4 is very important. Then moving forward to heart. Now heart has got different surfaces, different borders. Inferior surface of heart is formed by both the ventricles, whereas the base of heart is formed by both the atriums. Right? So base by both atriums, inferior surface by both ventricles. Then you must know what structures form the right border and what structure forms the left border of heart. There are three structures which forms the right border. One is superior vena cava, then right atrium, and inferior vena cava. There are four structures which form the left border. One is arch of aorta, second is pulmonary trunk, third is left atrial appendage. Please note, it is not left atrium, it is left atrial appendage, and fourth is of course left ventricle. Apart from this, the apex of the left ventricle is formed by of the heart is formed by left ventricle. Clear? So these are few anatomical points related to heart: right border, left border, and apex. Then the heart get its blood supply from coronary arteries. There are two coronary arteries, one is right, another is left. The right one especially supplies the conduction system like SA node in 60%, AV node. In the remaining 40%, SA node is supplied by the left coronary artery through the circumflex artery. Clear? So this is very important. And moreover, the right side of the heart mostly is supplied by right coronary artery. So right ventricle, right atrium, and posterior 1/3 of interventricular septum. Left coronary as the major contribution. So 40% of persons SA node can be supplied, then left ventricle, left atrium, and anterior 2/3 of interventricular septum. Right? So this is the major arterial supply. Now if we discuss, like say this is the right side of the heart, okay, so this is all right coronary artery. Then say this is the left side of the heart, this is all left coronary artery. Now the anterior 2/3 of the ventricular septum is left coronary artery, and the posterior 1/3 of the interventricular septum is all right coronary artery. Clear? So this is interventricular septum. Fine. This is all left ventricle, this is right ventricle. Clear? So this is how the coronary arteries provide blood supply. So SA node in 60%, AV node and the conduction system is all right coronary artery, and right coronary artery arises from the anterior aortic cusp. Now sometimes we use the word dominance, right dominance or left dominant. So what we need to do, we need to check for the origin of posterior interventricular artery. If it is originating from right coronary artery, you will say it is right dominance. If the left coronary artery is giving off this branch, you will say that this is left dominance. So right, so that is the concept of right and left dominance. So in right dominance, PIVA is coming from right coronary and vice versa. Anterior wall of left ventricle is supplied by left anterior descending artery. Then coming to venous drainage, now right atrium is the final point of drainage. So from superior vena cava, inferior vena cava, and the main venous channel of heart, that is coronary sinus. So all these they drain into right atrium. There is one middle cardiac vein which lies on the posterior aspect of the heart and in the posterior interventricular groove, where it accompanies posterior interventricular artery, that is PIVA. Then moving forward to lung, here you need to remember one thing, that there is a gap of 2 ribs between reflection of lung and pleura. So lower limit of lung and lower limit of pleura, there will be 2 ribs gap. Clear? So how we can understand that? Like suppose if I am drawing a line through the middle of clavicle, right? So this is the mid clavicular line. It passes through the 6th rib. Clear? And that is the lower boundary of lung. So 6th rib here. And if you draw it downward, it passes through the 8th rib. And this is the lower boundary of the pleura, right? So lung here, pleura here. So you can see there is a gap of 2 ribs. Clear? So similarly, if we draw a line through the middle of the axilla, it will cut the 8th rib for the lower border of lung, and similarly it will cut the 10th rib for the lower border of the pleura. So there has to be a difference of 2 ribs, and that is all the pleural space. Clear? So lung in mid axillary 8th rib, pleura in mid axillary 10th rib. So you can see there is a gap of 2 ribs. Then coming to arterial supply of adrenal gland, which is also known as suprarenal gland. Now there are 3 arteries, one coming from above, one coming from below, and the third one coming like this. So superior, inferior, middle. Superior is coming from inferior phrenic artery. So this is the inferior phrenic artery, which is giving off the superior suprarenal artery. Then inferior is coming from renal artery. So this is the renal artery, and the middle is coming directly from the abdominal aorta. Right? So this is abdominal aorta. So these are the 3 arteries and which are supplying the adrenal gland, named as superior, which is from inferior phrenic artery, middle directly from abdominal aorta, and third is inferior suprarenal, which is coming from renal artery itself. So this is the adrenal gland here. Okay, this one is the adrenal gland, also suprarenal because it is above kidney. So these are all superior suprarenal artery which are coming from the inferior phrenic artery. Then this is the inferior phrenic artery, inferior suprarenal artery, which is supplying like this, and it is coming from the renal artery. And then this is the middle suprarenal artery, which is coming from the abdominal aorta. So very typical arrangement for suprarenal arteries. Then if someone gives you a sample of kidney, now how you can say whether it is right side or left side? So for that you need to remember the mnemonic VAP, and this is anterior to posterior. So anteriorly, the most anterior structure is renal vein, followed by renal artery, and third is renal pelvis, which continue down as ureter. Right? So anterior to posterior, if you can arrange these structures, you can say whether the given kidney is of right side or left side. So remember, VAP. Length of ureter is 25 centimeter, and there are three important constrictions in ureter. One is pelvi-ureteric junction, where the pelvis becomes ureter. Then second is at the point of entry into pelvis, and third important constriction is uretrovesical junction, when the ureter enters into the urinary bladder. So these are the three important constrictions, and clinically this is the most narrowest one, and a renal stone or a ureteric stone can stuck here and it can cause very severe pain. So therefore one should know the constrictions, and if there is renal colic, one should understand that the stone is impacted at either of these two important constrictions, PUJ or UVJ. Then there is one urogenital diaphragm, which is found by sphincter urethrae, deep transverse perineae and perineal membrane. Moving forward to thalamus, which is an important relay station for sensory pathways. Clear? So all the sensory pathways, they will firstly reach to thalamus, and from thalamus the third order neurons will reach to brain. Right? So all sensations like carried by spinothalamic tract, or dorsal column, clear, even vision, so all the sensations will reach to thalamus first. So thalamus is the relay station. Now for hearing, the thalamic nuclei is medial geniculate body, and for vision the thalamic nuclei is lateral geniculate body. So all the sensations, they have to reach thalamus first, except olfaction. Otherwise all sensations reach thalamus first. Now how to remember like medial for hearing and how to remember it like lateral for vision? So here you can remember hearing as music. So please remember M of music and M of medial geniculate body. Then obviously lateral will be for vision. So this is how you can remember. Then another important structure is the internal capsule. Now here you can see this is thalamus, this is lenticular nucleus, and this is the caudate nucleus. Clear? So lenticular laterally, thalamus medially, and in between you can see the internal capsule, which has got anterior limb, posterior limb, and genu. Clear? So anterior limb, posterior limb, and genu, and this angle is actually laterally. So this is the internal capsule. Now why internal capsule is so much important? Because all the structures, all the tracts actually which are going above will pass through internal capsule. Similarly, all the fibers which are coming down will come through internal capsule. So it contains ascending fibers, it contains descending fibers, and therefore if there is injury to internal capsule, usually a vascular injury, in case of stroke, the manifestations are widespread. Right? Now, in the posterior, now in the genu, we can have fibers, sensory fibers, which are going from thalamus to brain. Now, one important fibers which are present in the posterior limb are the corticospinal tracts. Clear? So these are the corticospinal tracts, which you call pyramidal tracts. Clear? And they are carrying the command from the brain and other areas, which is going down to the muscles. So that is corticospinal tract. So very important to understand this. And there are two more parts: retrolentiform, which is for optic radiation, and sublentiform, which is for auditory radiation. I think lentiform, you must understand, it is putamen plus globus pallidus. Now you can remember this as ROSA. Clear? So this is retrolentiform for optic and sublentiform for auditory radiation. And here you can see this is the lateral geniculate body, and this is concerned with optic radiation, and this is the medial geniculate body, which is concerned with auditory radiation, that is music. Right? So this optic radiation, this part is the retrolentiform, and then auditory is all, this is the sublentiform. So this is how you can understand. Then moving forward to vascular injuries, which is actually stroke. It can be hemorrhagic or embolic. Now here the brain as such is supplied by three arteries, three cerebral arteries, you can say. So anterior, middle, and posterior. So these are the three cerebral arteries. Clear? So you can say it as cerebral arteries. Now the anterior one supplies the medial part of the brain mostly. The lateral one the middle one supplies the lateral part of the brain. So anterior, medial, middle, lateral, and posterior supplies the occipital area, occipital lobe. So this is usually occipital. And we know that in occipital there is visual area or visual cortex. So posterior is usually related to vision. You can write it like this. Now the lateral part and medial part, this is related to homunculus. So like if you have read about motor and sensory homunculus, in which the body is represented in an upside down manner. So lower limb here, head, neck here, then upper limb, trunks, pelvis, like that. So what I mean to say, if there is blockage somewhere here, clear? So that will affect the upper half, that will affect the respective part of the body as per the homunculus. Not the entire body will be paralyzed. It will be only the part which is represented in this particular area of the homunculus. So that is the importance of knowing homunculus. Now, when there is involvement of one side of artery, the manifestations are on opposite side. So if I say left middle cerebral artery, it means the manifestations will come on the right side. Now here we have both motor area and sensory area, so we'll have involvement of both the areas as per the homunculus. So there will be right sided hemiplegia, there will be right sided sensory deficits of face and arm. Similarly, if I use the word right, the manifestations will be shown on the left side in terms motor terms, that is hemiplegia. In sensory terms, there will be anesthesia or sensory loss. Right, you have to mention the manifestations on left side. Posterior cerebral artery, that is all visual loss, very easy to identify. Then lateral medullary syndrome, this is because of occlusion of posterior inferior cerebellar artery, and this is written as PICA, PICA. Then moving forward to basal ganglion. Now here you should remember the 5 parts of basal ganglion, and this question usually comes most of the time as an image based question. Either it can be a MRI or a line diagram. So here what you can see, this is thalamus, clear? This is thalamus here. This one is the caudate nucleus. If you go laterally, this one is putamen. Deep to putamen is globus pallidus externa and globus pallidus interna. Lower down you can see subthalamic nucleus and substantia nigra. And this is the internal capsule, right? So suppose if this is the internal capsule, on the top you can see the caudate nucleus. So this is the caudate nucleus. This is of course internal capsule. Clear? Then here we have the thalamus. So this is the thalamus here. Then laterally we will see putamen. So this is the putamen. Deep to putamen there is globus pallidus externa, and deep to globus pallidus externa there is globus pallidus interna, right? So this is the arrangement, and together this all is known as lenticular nucleus. Clear? Lower down you will have, below the thalamus you will have, you can say, subthalamic nuclei. So here there is subthalamic nucleus, and below that we have substantia nigra. So please remember this because it is a very important question, and most of the time we have a image based question out of this concept. Then moving forward to cranial nerves, brain stem has 3 parts: midbrain, pons, medulla. From midbrain there are 3 nerves. There are 2 nerves, 3 and 4. From pons we have 4 nerves, 5, 6, 7, 8, and the remaining 4 they have their nuclei in medulla, 9, 10, 11, 12. Remember, first and second they directly continue, they don't have a nuclei. Now there is only one nerve which emerge from the posterior or dorsal aspect of the brain stem, and therefore it has to travel little longer, and therefore it is having longest intracranial course because it is coming from behind. Apart from that, all other nerves they emerge from the anterior aspect. Facial expression muscles, they are supplied by facial nerve. Now hypoglossal nerve, if it is paralyzed, especially lower motor neuron lesion, the tongue will deviate to same side. Means if there is right lower motor neuron 12th nerve palsy, and if you tell the patient to protrude the tongue will deviate to right side. So you can see easily that this is a right lower motor neuron 12th nerve palsy. Facial nerve supplies submandibular, sublingual, lacrimal, nasal gland, but please remember that facial nerve travels through the substance of parotid but does not supply parotid. Parotid it supplies by ninth cranial nerve. Then some skull foramina, optic canal. As the name suggests, it will give way to optic artery along with ophthalmic artery. Clear? So this is ophthalmic artery. Foramen rotundum. It gives way for second division of trigeminal nerve, 5-2. So because 5-1 is ophthalmic, right? 5-2 is maxillary, and 5-3 passes through foramen ovale, that is mandibular. So from foramen ovale you can remember the mnemonic male, M for mandibular division of cranial nerve 5, that is 5-3, accessory meningeal artery, lesser petrosal nerve, and emissary vein, which are actually the bridging veins. Foramen spinosum is a very small foramen, but it is very important clinically because it gives way for middle meningeal artery, and I think most of you must be knowing that if it is injured, there is extradural hemorrhage. Clear? So the CT scan finding will be something like this, concave or convex. Apart from this, meningeal branch of mandibular nerve. Right? So if you see here, this number 6 is the spinosum, number 5 is the ovale, and number 7 is the lacerum. Right? So number 7 is lacerum. No, nothing passes through foramen lacerum, that is number 7. So 5 is ovale and 6 is spinosum. Then this one is foramen magnum. The largest of all is the foramen magnum, and it gives way for spinal accessory nerve, vertebral and spinal arteries, and most important, it gives way for medulla, which later on becomes spinal cord. So it is not the spinal cord proper which comes out through foramen magnum, it is medulla. Please remember that. So this is foramen magnum. Then foramen jugular foramen, again you can remember internal jugular vein, so this way you can remember IJV. Then inferior petrosal sinus and 3 cranial nerves, 9th, 10th, 11th. So this is from jugular foramen. Internal auditory meatus, it gives way for 2 nerves, 7th and 8th, and out of the 4 quadrants of internal auditory meatus, 7th is here, 8th is here. Then on the other side, this is superior vestibular nerve, this is inferior vestibular nerve. So please remember this arrangement. So 7th is above. Apart from this, there is labyrinthine artery which is passing through the internal auditory meatus. Then CSF, it is produced by choroid plexus. Now the circulation, there are 2 lateral ventricles in the cerebral hemispheres, right? So these are the lateral ventricles, the cavities within the cerebral hemispheres, right? So you can say this is all cerebral hemisphere. Then this is the 3rd ventricle, and lower down is the 4th ventricle. Clear? So there is no first and second, because actually there are two lateral ventricles. So that is in other terms taken as first and second. So two lateral ventricles, one on the right side, another on the left side. Then they connect with the third ventricle through foramen of Monro. So this is foramen of Monro. Clear? Then the third ventricle connect with the fourth ventricle through the aqueduct of Sylvius. So this is aqueduct of Sylvius. Now the fourth ventricle have a central channel and two lateral channels. Clear? So these lateral channels are known as foramen of Lashka, and the central channel is known as foramen of Magendie. And through these Lashka and Magendie, through these channels, the CSF final reaches into subarachnoid space, which is surrounding the cerebral hemispheres and the spinal cord. Clear? So this is the circulation of CSF. Two lateral ventricles, foramen of Monro, third ventricle, aqueduct of Sylvius, fourth ventricle, two foramen of Lashka, and one foramen of Magendie. Now, the absorption is the important thing to control CSF pressure, and this is done by arachnoid granulations. So this is how CSF is produced and absorbed. Total volume is around 150 and the pH is 7.33. In a normal sample of CSF, neutrophils are never seen. We can see lymphocytes. Few lymphocytes can be seen, but never neutrophils. Clear? And if you see neutrophils, I think most of you can answer. This is pyogenic or bacterial meningitis. Fine. Moving forward, some important areas in the brain. Now say this is the frontal lobe, this is the temporal lobe, this is the parietal lobe, and posteriorly here we have the occipital lobe. Clear? So this is parietal, frontal, temporal, occipital. Now the superior temporal gyrus is important area in terms of hearing of voices. So one primary auditory area here, superior temporal gyrus. Apart from this, there is also Wernicke's area. So Wernicke's area is also here. Then Broca's area is in inferior frontal gyrus. So the Broca's area is somewhere here, inferior frontal gyrus. So this is inferior frontal gyrus, and this one is superior temporal gyrus. Clear? So Wernicke's here, Broca's here. Then visual area is here. So primary visual area is in occipital lobe. Limbic system is concerned with emotions, memory, higher functions. Then pinna, which is the part of external ear, it is supplied by auriculotemporal nerve, then facial nerve, and most importantly auricular branch of vagus. Clear? So these are some important nerves which supplies pinna. Tongue. The muscles of the tongue, they develop from occipital myotones, and the safety muscle of tongue is genioglossus. Now genioglossus makes sure that the tongue does not go backward and block the respiratory passage. So therefore it keeps the respiratory passage open, so it is known as safety muscle of tongue. Posterior one third of tongue is supplied by glossopharyngeal nerve, which also supplies the middle ear. So sometimes if there is pain from carcinoma base of tongue, it might be felt in middle ear because they have the common nerve supply. So posterior one third tongue and middle ear, the nerve supply is same, CN9. Therefore, pathology may be at some place, but brain will perceive pain sensation from some other place because the nerve is common. Anterior two-third of tongue develops from lingual swelling and tuberculum impar, whereas posterior one-third of tongue develops from hyperbranchial eminence. So this is in terms of development. Now taste sensations, right? So this is taste sensations from anterior two-third is carried by chorda tympani, and general sensations. Now taste is sweet, sour, bitter. Taste is hot, cold. So this from anterior two-third of tongue is carried by lingual nerve. So this is very important. Anterior two-third of tongue, different nerves for different function, but from posterior one-third of tongue, it's all CN9, which is taking general sensation as well as taste sensation. So if we draw like this, so say this is the anterior two-third of tongue, this is the posterior one-third of tongue, right? So this is posterior one-third, this is anterior two-third, and this is the landmark is sulcus terminalis, right? So this is one sulcus which differentiate. So anterior two-third different nerves, posterior one-third just one nerve. Tonsil is supplied by ninth nerve, that is glossopharyngeal, and the lymphatic drainage goes to jugulo-digastric lymph node. Moving to larynx, there are 9 cartilages in larynx, 3 paired, making it 6, and 3 unpaired. So 6 plus 3 becomes 9. Now the unpaired cartilages are epiglottis, right? Then thyroid, and the third one is cricoid, right? So epiglottis, thyroid, cricoid. Paired, one right side, one left side. So this is arytenoid, corniculate, and cuneiform. Clear? So this is now with respect to the vocal cord, sensations above is given by internal laryngeal nerve and below is by recurrent laryngeal nerve. So suppose if this is the level of vocal cords, this is all internal laryngeal nerve and this is all recurrent laryngeal nerve. So different nerves, and this is of course vocal cord. Different nerves taking the sensations. All muscles of larynx, they are supplied by recurrent laryngeal nerve, but there is one exception, and that is cricothyroid, which is supplied by external laryngeal nerve, right? Apart from this, all other are supplied by recurrent laryngeal nerve. Abductor of vocal cord is posterior cricoarytenoid, and it keeps the airway patent. Therefore, it is known as safety muscle of larynx. Clear? Just like we discussed genioglossus as safety muscle of tongue. Cricothyroid is tensor of vocal cord. Now moving forward to temporomandibular joint, depressor of mandible. This is actually opening of mouth, and this is brought about by lateral pterygoid assisted by gravity. Protrusion means forward projection of mandible, and this is by both pterygoids. So medial plus lateral. And retraction, taking a protracted mandible back, is retraction. This is done by posterior fibers of temporalis. Now moving forward to eye. Extorters. Extorters means outward rotation. This is done by both inferiors, that is inferior rectus, inferior oblique. Intorsion. Intorsion is inward turning, and this intorsion is done by both superiors, again superior rectus, superior oblique. Superior oblique is supplied by trochlear nerve, and its action is abduction, depression and intorsion. So suppose if this is the right eye, it will take it outward, so this is abduction. It will push it downward, so that is depression, and it will rotate it internally, that is intorsion. So this is all action of superior oblique, which is supplied by cranial nerve 4, and the mnemonic is SO4, lateral rectus by 6th, and all the remaining muscles by 3rd. Clear? Now there are certain excepts in anatomy, like we already discussed that all intrinsic muscles of the larynx are supplied by a recurrent laryngeal nerve, but the exception was cricothyroid, which was supplied by external laryngeal nerve. Similarly, there is an exception in tongue, where the muscles of the tongue are supplied by hypoglossal nerve, and the exception is palatoglossus, which is supplied by pharyngeal plexus. Similarly, there is one exception in pharynx, where all the intrinsic muscles of the pharynx are supplied by pharyngeal plexus, but the exception is stylopharyngeus, which is supplied by glossopharyngeal nerve. Remember, pharyngeal plexus 3rd, so stylopharyngeus. And then all the muscles of the soft palate are supplied by pharyngeal plexus, except tensor palati, which is supplied by nerve to medial pterygoid. So these are some exceptions to the rule of common nerve supply to a group of intrinsic muscles. So this is enough for this session. I'm very sure you must have enjoyed the session. I'll be back shortly with another subject in this rapid revision series. Till then, keep on studying, stay blessed, goodbye.